Good afternoon, everyone. This is today's PHSSR Research in Progress series. Our theme today is Bridging Health and Healthcare, integrating public health and healthcare lessons from one urban county. I'm Rick Ingram. I'm a professor at the University of Kentucky College of Public Health. I'll be the moderator today. Our presenter is Erik Carlton, DrPH. Erik is an assistant professor of health systems management and policy at the University of Memphis School of Public Health. Erik's current research focuses on integrating public health and primary care systems, integrating behavioral health into healthcare and public health systems, and also public health leadership and workforce development. He teaches the healthcare and management leadership, health policy, and organization of health systems, and healthcare quality and outcomes management courses for the University of Memphis. Go Tigers. Dr. Carlton holds a Doctor of Public Health degree in Health Services Management from the University of Kentucky. Erik is a friend and colleague and a great researcher. We have two kind of commenters today. First one is Paul Irwin. Paul, MD, is a doctor. He's a professor and leads the Department of Public Health at the University of Tennessee, Knoxville. Before joining UT, Paul worked with the Tennessee Department of Health for 16 years. He's boarded in internal medicine and public health and preventive medicine and is a fellow of the American College of Preventive Medicine. He serves on the editorial boards of the Journal of Public Health Management and Practice. He also serves on the Scientific Advisory Committee for the America's Health Rankings. He's also on the Research Advisory Council for the Public Health Accreditation Board, the Board of Directors for the Tennessee Institute of Public Health, and the Board of Directors for the Public Health Foundation. His research interests are in the emerging field of PHSSR, focusing in particular on local and state health departments, population health outcomes, and health disparities, particularly in rural areas. Paul's currently leading a public health PBRN in East Tennessee, which involves public health practice partners of the Knox County Health Department and East Tennessee Regional Health Offices, and a Robert Wood Johnson Foundation funded projects exploring geographic variation in health department services. Our other commenter today is Crystal Miller. Crystal's Public Health Director for the Wedco District Health Department, serving Bourbon, Harrison, Nicholas, and Scott counties in Kentucky. Crystal is a graduate of the National Public Health Leadership Institute and has received her MPH from the University of Kentucky College of Public Health. She currently serves on the Kentucky Health Department Association Executive Committee and is a member of the National Association of County and City Health Officials Board of Directors. Crystal is also currently a candidate for her DrPH degree at the University of Kentucky College of Public Health. So thanks for coming. Erik, would you like to start?
Sounds great, Rick. Thanks.
Thank you.
Great. Thank you all for being here. Good afternoon to those of you on the East Coast, and good morning to the rest of us. I'm grateful to be with you this morning. As we get started, I should share that I don't have any relevant financial conflicts to disclose, though as a pre-tenure faculty member, if any of you out there are funders and would like to establish a relevant financial relationship, my contact information is at the end of the presentation. I want to acknowledge more seriously the role and support of the Robert Wood Johnson Foundation and the National Coordinating Center for Public Health Systems and Services Research for providing the funding for this study, and as well as additional support provided by the University of Memphis School of Public Health, and to my good colleague, Dr. Paul Irwin at the University of Tennessee, for providing some very keen mentorship throughout this study. That would not have been possible without the support of these individuals and institutions. I'd like to frame our discussion this morning, this afternoon, with the following quote: "A major deterrent to our efforts to fashion healthcare that is efficient, effective, comprehensive, and personalized is our lack of a design for the synergistic interrelationship of all who can contribute." Now, I was struck by the statement when I read it, and struck for a number of levels, perhaps mostly because of how long ago it was stated. This is from a report that's over 40 years old from the Institute of Medicine. 40 years ago, and we're still finding our way. Now, I think, and many of us would feel this way, that we're getting closer. We have some very recent reports. There's a lot of effort going on. Certainly the IOM report on primary care and public health integration, a supplement to the American Journal of Public Health a couple years ago, and I might also point out to you a very recent report issued just in the last couple weeks out of a study of 12 health department hospital collaborations across the country, conducted by our good colleagues, Dr. Pribble and Dr. Scutchfield there at Kentucky and others of their colleagues. The report is titled Improving Community Health Through Hospital Public Health Collaboration and is available on the National Coordinator Center's website. I think what it does is it highlights that the idea of integration between healthcare and public health is much broader than just primary care. In fact, and especially in a lot of urban areas, there are major hospital healthcare systems, if you will, that are buying up and aligning physician primary care practices. And so the primary care is increasingly being defined by the notions, the themes, the mission, vision, and values of these larger healthcare systems. And so as public health researchers and practitioners, I think we need to be aware of that and understand those contexts that we're operating in, and certainly it frames this study. But I think the principles of integration that are outlined in the IOM report still hold true. And the next couple slides are just for reminders, refreshers to those of us who have already read this and should give some framework to those who haven't. But there are 5 basic principles here outlined. Having a shared goal of population health, having a sense of community engagement and engaging the broader community in the efforts, having aligned leadership between the different agencies and institutions, attending to issues of sustainability, and then having a system of shared data and analysis that helps to guide and measure efforts. Now, the IOM report helps us to understand this concept of integration in a couple of different ways. First, by providing a definition. They focus on the linkage of programs and activities to promote the overall efficiency and effectiveness and achieve gains in population health. And this concept of population health, I think, needs some attention. It's a concept we still need to better and more uniformly define. As we talk about that today and maybe in our conversations, we should probably be willing to at least accept or understand a dual meaning that healthcare organizations, because they have a responsibility for groups of specific patient populations that are often defined by geography, but more often and usually in terms of conditions and diseases, they think in terms of population health in that aspect, in terms of these specific patient populations, and not as often in terms of their geographic populations. Now, public health is quite the opposite, and certainly as a governmental public health function, agency function, has a responsibility for a very well-defined community, whether it's a city or a county or a state, in some cases certainly for the CDC a national sort of responsibility, but that's when we hear the term population health, and until it is clarified across the disciplines, we might benefit from thinking in terms of the health of populations and allow some gray area to exist as much as that creates a tension for those of us that want to categorize everything. Now, the IOM report spells out these different types of integration from the different levels to the partners that act within each of those levels, the different programs and activities, and then provides a continuum from isolation to merger. And the report is very clear that we probably don't want to have a completely isolated healthcare and public health systems operating entirely unaware of each other and separate from each other, nor do we usually want to see a complete overlap between healthcare and public health, and it's likely that neither of those will occur. The idea behind a lot of our efforts to better understand collaboration is to understand how do we move from just an awareness of each other into levels of or degrees of better integration that involve cooperation and then collaboration and in many respects greater partnership. Now the next couple slides I want to borrow from a colleague and good friend of ours, Dr. Glenn Mays, who I think really captures the context in which this study and others operate, and the reasons why we fail to connect between the two. Healthcare is increasingly seen as fragmented. There's a lot of duplication of services. There's a lot of practice variability, even within specific disciplines of healthcare. Often there's limited access, whether because of cost or systemic barriers like transportation, geography. Healthcare is often defined by episodic and reactive care. has been seen to be insensitive to consumer values and preferences, though maybe some of that is changing through patient-centered medical home, accountable care organization, patient-centered outcomes research sort of efforts. And in many ways, there's been a limited targeting of resources to community needs, even with community benefit. How much of that actually goes to community needs that are prioritized and can be changed by that investment? Likewise, on the public health side, there is fragmentation. There's a lot of, and we all know this, very constrained resources across the country. Funding is being cut for public health, and public health directors are being strained to come up with what they need to accomplish their stated objectives. Because of this, there is some practice variability. There's more limited reach, sometimes insufficient scale of activities. And in many ways, the public doesn't understand what public health is. They often think in terms of making sure the pools are safe or seeing the sign in the restaurant that says that the kitchen's clean. But understanding the larger function of public health to improve the health of the community is sometimes pretty misunderstood by the public as well as by other professions. There's a limited evidence base to a lot of what we do. We don't do RCT trials for tobacco prevention policies. We don't operate at that level. Certainly, I think that the work we do within PHSSR is turning the tide there, but it is still an area where we are slow to innovate and to adapt, and that leads to, on both sides, to inefficient delivery, inequitable outcomes, and potentially this limited population health impact. So again, borrowing from Glenn, why now? Why do we look at bridging the gap now? And I might say, why not? With everything that is happening across both healthcare and public health, why not now? If we're truly reforming health and healthcare, then let's make sure we examine this relationship between these sometimes parallel, sometimes diametric, and often overlapping systems. And that's really at the heart of this study. The core question that we took was what conditions and strategies facilitate productive interorganizational relationships and patterns of interaction among healthcare, primary care, and public health organizations. This is a question that's adapted from and drawn from the Agenda for Public Health Systems and Services Research. Now, I should be clear from the outset here that this is not your father's multi-level quantitative modeling study, nor is it your grandmother's traditional regression analysis. This was and is a dirty, emergent, in vivo qualitative research study, drinking from the experiential source, if you will. But I don't think that means that it did not have rigor, and I am grateful to see that there is increasing room at the table for those of us who do qualitative health services research. The methods we used were a combination of semi-structured key informant interviews with what I call a modified snowball sampling procedure. Now, just let me briefly explain both of those concepts. I think most people understand key informant interviews. A structured key informant interview would be an interview with a specific representative of an agency, somebody who can comment on a process, but with a very defined structure. We only ask these 6 questions, for example. Semi-structured allows for a core set of questions that we really want to ask, but allows us to ask more follow-up questions to follow the informant, the research participant, where they want to go and the themes that they want to discuss. It's a little bit more nebulous, but has an opportunity to afford a much deeper, richer illumination of concepts. And then a snowball sampling procedure is one that is best characterized by, at the end of an interview, asking the participant, okay, now that we're done, who else do you think I should talk with or speak to? And now, we knew going into the study a lot of the people we wanted to talk about or speak with, excuse me. And so we had some targeted participants. So we used a modified snowball sampling procedure in the sense that we targeted some participants, but then we let them inform us on others. We knew who the CEOs of the major hospital systems were. We knew who the health department director was. We knew who the mayor's health policy advisor or the major players within some of the health-oriented community nonprofit organizations were. but we, I think, wanted to be sure that we didn't miss somebody that had an important role to say. And truth be told, as we talked to people, they pointed out other people that we might not have reached out to. And there were several people involved who were not in these traditional executive roles, who have been former executives or have executives in other functions, certainly get leadership concepts, who get the major themes at work here, but that we might not have identified traditionally. And so that's the method we used. Our sample ultimately involved hospital, health departments, and health-oriented community nonprofit executives, a total of 17 of them. It was located within one urban county, and the analysis involved 3 different procedures that we used to triangulate the findings. Now, in traditional quantitative research, there are a lot of methods we do to control for bias and attend to issues of power and a number of other rigor-oriented methods. Now, in qualitative analysis, we do the same thing. We used a code-recode procedure, which is, for those of you not familiar with qualitative research, it's basically sitting down, looking over the transcripts of some of these interviews, coding some of the themes, saying this seems to be the things that they're talking about, and highlighting those, and then stepping aside and coming back a couple of weeks later when we haven't thought about those. We have very busy lives, and life goes on, and we don't think about them all the time. But we come back to them and we say, okay, let's look at another blank copy of this transcript and let's see what we come up with. And then you compare the codes that and the themes that you identify and see where there's some overlap and see what really are the key concepts coming out of these studies. And that's how we develop the coding procedure. Part of it, too, in terms of triangulation is recognizing that I, as a researcher, go into this with bias, with assumptions, with understandings. And if I don't attend to those and don't account for my own bias as a researcher, as a qualitative researcher, then I can muddy the waters. And so having a reflexive field journal does a couple things. One, it helps to track the themes that are developing as they come while I'm interviewing people, but it also helps me to write out ahead of time what I'm bringing into this study, what my biases are, where maybe I'm being surprised or where some of my biases are being confirmed or identified. And it just helps to not neutralize or control for, because you can't do that, but certainly to attend to bias. And then finally, and perhaps most powerfully, this notion of member checking, where as the analysis is moving forward, as we're starting to put together some of the draft reporting, going back to those same research participants and saying, in essence, this is what we're finding. Does it resonate with you? And if it does, then we're on track. And if it doesn't, then they can correct us and they can point us in the right direction. And in that extent, we have a very rigorous qualitative process that allows for the rich experiences of people who are doing the work we want to understand to come out very fully. Now, to get into the results, in terms of demographics, you see we have a very balanced, I would say, gender perspective, both male and female participants involved. There was not as much balance in terms of race as I would have liked to see, but kind of reflective of the executives that we have around here. Unfortunately, there's not as many Black or African American executives that were in these positions of leadership to really inform the study, and maybe speaks to some other issues, but not one that we're going to address a whole lot here. And then finally, in terms of their primary job title or position, you see that there were about a quarter of them, a little over a quarter, who were either hospital or healthcare chief executives, another third who had a presidential or C-suite sort of role within a healthcare organization, one executive from a health department. There were 4, or about a quarter of the participants, who were from nonprofit groups and had executive leadership roles within those, and then one other participant who didn't really fit with any of these other categories, but was somebody that a lot of participants had identified needed to have input on this study using that sampling procedure. So as we move forward, I talked about these themes. What's always interesting is finding what themes come up, and interestingly, there were three themes. This doesn't happen a lot in qualitative research, but there were three themes that everybody mentioned. All 17 of these participants at some level talked about these three themes: having a focus on targeted and shared issues, building on current collaborations or past collaborations that were successful, and developing and supporting a strong convening agency. All but one, as I recall correctly, talked about the importance of involving payers and business partners, people outside of just healthcare and public health. And then a couple other themes that rose to the top: training the workforce that we'll talk about, and then leveraging the Affordable Care Act and other market forces to really push forward the transformation. This other theme that you'll see here that's at 82%, enhancing policies to encourage collaboration, we folded that into leveraging the ACA and market forces because it was about policy, both of those themes, and so we ultimately put those together. So here's our set of key themes that we're going to talk about here in the time we have remaining. First off, having safe, shared, and targeted issues. All the participants recognize that we need more bridges between systems. We need to find ways to connect better. And they focused on finding common denominators. Interestingly, a number of them talked about leveraging shared poor performance. As this quote here at the bottom from one of these participants said, "Why are we competing on this? No one is doing a particularly stellar job." We can look around the community and we can see what our issues are. And it's clear that we're not doing a good job on these. So it doesn't behoove us really to compete. This is an area where we could collaborate. Now, and to follow up on this, and I think perhaps none of the concepts I'll talk about today is more fundamental than this. One of the participants, who's a former CEO of perhaps the most renowned healthcare organization in the world and board chair of, the safest way I can say it is an international healthcare improvement organization. It's somebody who's here locally and deeply involved in these efforts. And he says that we need to get beyond who has the better billboard. We can compete on the clinical determinants of health and collaborate on the non-clinical determinants of health. I'm not sure if anything hit home more to me as a researcher and to others as we talked about this than this concept here. Yes, we want medicine to be the best it can be. We want excellent outcomes. We want excellent patient experience. We want excellent cost. And competition can get us there. However, I think, and the participants really resonated with this, if we can make this idea happen, if we can really get to collaborating on the non-clinical determinants of health and focus our efforts there where there isn't going to be as much resistance from the healthcare side, where there isn't going to be as much resistance from businesses or other players, we might truly turn the collaborative Titanic, so to speak. We might actually get to where we want to go in terms of bridging the healthcare systems. Now on to a second theme, the role of businesses and payers outside of just these healthcare and public health agencies was brought up across the board by our participants. And the notion of engaging the business community that has such an investment, especially large employers, and in terms of what healthcare outcomes are and what costs are, having better outcomes among their employees. And then the payers, the insurance companies, they're critical players in the conversation around collaboration. But there is a larger non-health market voice that we need to attend to, where there are fundamental incentives for improvement and change. The economy is so much bigger than health and public health and healthcare. Our civil structure is far broader than hospitals and public health departments. I think what the participants are telling us here is that we need to be careful of myopia and try and think in terms of overlapping interests. By doing that, we can leverage a far greater support and resources and help to develop the collaborations we're trying to develop by getting beyond our walls. As this participant said, she's a lady who convenes a group of employers who are really interested and concerned by health issues in the community. She says, we need a broader definition of who's involved in changing health. Healthcare is the smallest percentage of those with influence. And to me, that really struck me, because I think sometimes we think about just how much of the economy around health is driven by health care. But in terms of the larger economy, there's so much more outside of it. She's saying, what about education? What about business and economic development? We need to get out of silos and have a whole cadre of people who care. I think a critical theme that we need to attend to. Now, a third theme in terms of workforce training, participants all across the spectrum are very clear on this, that we have very siloed educational and professional models that create different languages, values, and perspectives. And while certainly some of those values and perspectives drive our career choices, it doesn't mean that we have to reinforce them with our educational models. One participant, a former state health commissioner, says, we're simply not trained to work across the divide. Public health needs to quit talking to itself. Healthcare needs to quit talking to itself. Our successes are when we start talking to others. We need to speak in a language the other understands. And that demands, at some level, a retooling. And how are we retooling our current workforce to operate in this more collaborative arena? How can we maybe redesign our educational models to be more inclusive, more interdisciplinary, more transdisciplinary even? I think are important questions for us to ask. These participants are telling us we need to think about these issues. How do we work across this divide if we don't have the skills and the knowledge and the language to do so? Now, a fifth theme that came out was the role of policies and market forces. And when we know there are a number of incentives and disincentives that drive private sector collaboration. We know about community benefit. Some of the participants suggested that maybe we need to look at how those community benefits incentivize collaboration. Can we give them more teeth, is what one of the participants said, so that really it's more meaningful for hospitals to be involved with each other as well as the health department and other players in the sector, in the various sectors of the community to really address health issues. They pointed out how competition, these market forces, especially competition between hospitals, can breed dissent and slow the process down. They don't want to play nice in the sandbox. And so what can we do to break down competition, again, around those non-clinical determinants of health where there isn't as much financial interest for the hospitals to compete? How can public health lead out and help to break down that competition? And I think we don't need a research study to tell us this, but we need greater investment in what population health is. And what these participants, and this one participant in particular, said is a substantial pool of investment beyond traditional governmental public health. The health departments can't do it all. In fact, they probably shouldn't. But I think that there is a leadership role for the health departments and for the hospitals together, and with greater investment, and again, we can do this by engaging the businesses, by engaging payers, by engaging members of other sectors in the process, to develop a pool where we can make room for the innovation in healthcare and public health services delivery that we really need. And that gets us to our final theme, which I think is one that you will see come up anytime there's any sort of study of interagency collaboration, is, well, who's driving the bus? And so the role of a convener was the final theme that came out of this study, final unifying theme that came out of this study. The participants talked about the new School of Public Health in the community. What is the role of the School of Public Health supposed to be? Or maybe there should be a public or population health institute, some sort of neutral Switzerland-type agency that can move forward issues without the political weight of any specific organization. They pointed out a number of existing health-oriented groups in the community. There's a business group on health. There's an Aligning Forces for Quality project. There's an IHI community-wide triple aim project. The county mayor has health-oriented initiatives and groups. But because there are so many of these health-oriented groups, nobody's driving the bus. In fact, in many ways, they're playing tug-of-war. And so how do you have a strong convening agency? What might the role of the health department be in there? The health department executive who participated in this study said, recognized that the health department has statutory responsibilities that transcend economics and other factors. For others, it's their choice to make a difference. And so really what the participants are telling us is that we need to attend to who the convener is, and are we supporting them? Are we giving them the resources and the structures that they need to be successful in bringing together very large institutions in many ways? Now, just to wrap up, there are some limitations to the study. Certainly the small sample size, while nothing to shake a stick at in terms of qualitative research, a sample size of 17 is 17. And how might it be different if we had 30 different people? Now, in qualitative research, we often work towards what's called saturation. And so when we start to find themes repeated over and over and over again, we realize we're not really coming up with anything new, and so we stop the study. And that's what happened here. There were more people on our list to interview, but the people that we were getting involved weren't telling us very new things near the end. And so we closed down the study with these 17. And finally, another limitation is the focus on one urban county. People would look at, well, what are the generalizability of findings? I think we don't worry so much about generalizability in qualitative research as much as we do about coming up with meaningful findings. And I think people who are practitioners or researchers in other communities looking at other problems, if there are themes that resonate, then they are generalizing. They are finding things that overlap and are more universal sort of themes. And so, but certainly having a focus on one urban county would be different. What are the perspectives in other urban counties? What are the perspectives in a more rural setting? Things for us to be aware of. Now, in terms of just a few implications for public health leaders, do public health leaders really understand how prevention and population health care fit with and enhance the overall healthcare corporate strategy? Do they understand incentives and disincentives to encourage hospital and healthcare participation in population health issues? If they do, then they can better leverage, especially for the nonprofit hospitals, the community benefit activities that might truly benefit the community. They can help their healthcare partners see where their investment can be truly meaningful and where they might actually save money in other areas by investing in a more shared collaborative approach to population health. And again, focus on encouraging collaboration where there is no competitive advantage, where we're operating on the non-clinical determinants of health. Other implications include enhancing training and workforce development activities with a shared language of and skills in population health and in collaboration. So not just those of us who are educators, but leaders in healthcare, in public health organizations as we're developing our people, making sure they really have the tools to work with their healthcare partners. How do we build on existing and past successes? If we have something that has worked in the past, if this community has come around and said, we're going to fix infant mortality, then we build on that and we go back to those relationships that we had, and we can draw on the trust that we developed in each other to say, hey, we fixed infant mortality. It's not all the way cured, but we cut it in half. And so we can come back to this and we can do this for other areas. We can look at cardiovascular disease. We can look at depression or substance abuse. We can look at these areas. And then targeting issues with a shared potential to gain small wins. A shared goal of population health doesn't start with saying, hey, let's all come together and work together. It has a very kumbaya feel that's going to break down real quick. But if you have a shared goal for particular health outcomes, like infant mortality, like cardiovascular disease, like child obesity, like depression, we can have a more focused conversation. Finally, and I thought this was really interesting, a number of the healthcare people I spoke with said that they want public health to lead out. And I'm not sure, certainly might be a conversation for another study, but why public health doesn't lead, or maybe they think they're leading, but not waiting to lead out, to lean in, if you will, in the conversation and say, we can own this. This is our area of expertise. Let us do this. This is what we can bring to you. So if public health leaders don't wait to lead, I think that we can move forward quicker. At least that's what this study would suggest. Now, some final perspective from one hospital president that I thought was very telling. He said at some level, we, meaning the healthcare side of things, have both a moral and an economic imperative to change how the system works. An economic imperative to save money, reduce costs and waste, and a moral imperative to both save lives and improve health. Then he said, those with a democratic imperative for a given population must own it. And I think the lesson for us, the takeaway, is those of us who are public health leaders, those of us who are public health researchers, we need to own it. We need to really, truly understand that this is something that we can do, that we can own, that we can make a mark. It might just be public health's greatest innovation in the 21st century. Here's my contact information for those who might want it. It'll be on the slides that are provided afterwards. And I, again, appreciate you being here and look forward to the commentary from research and practice perspectives and to questions and discussions that might be had. Thank you.
Great, Eric. Thanks so much. It was a fascinating presentation. Again, as I mentioned before, we have two reactors today. Paul Irwin, the Professor and Director of the Department of Public Health at the University of Tennessee, Knoxville, and Crystal Miller, the Public Health Director for the Wedco District Health Department in Kentucky. Paul, would you like to give us your reaction to Eric's presentation?
Sure. Thanks very much, Rick. And, thanks to all of you for joining today. Very honored to provide some comments after Eric's presentation. Eric, congratulations on a very nicely done piece of work here. Let me drop back and just make a couple of comments about context. I think Eric's work on exploring the barriers to and facilitators of improved linkages between primary care and public health is timely for a number of reasons, and Erik already mentioned several of these. First and foremost, several elements of the Affordable Care Act not only make integration feasible, it actually creates a platform or mechanism for synergy, and I'll talk about that term a little bit later. At least in three areas, new innovations across health information systems. For example, the opportunities to integrate electronically the electronic health records with public health surveillance systems. Second, new models of care, for example, ACOs. And third, the new concept of, or at least the way it's being newly packaged in patient-centered medical homes within the Affordable Care Act. But there are also two other aspects that make this work timely. Community benefits, requirements for nonprofit hospitals to engage public health through community health assessments. There is the opportunity to connect further with primary care providers because of their connections to hospital and hospital-based care. And then secondly, the common challenge that is faced in primary care and public health on chronic disease. I think here are opportunities to make the most of both evidence-based medicine and evidence-based public health. And let me add one more that makes this timely, and that's the unknown impact of the Affordable Care Act on both public health and primary care. It certainly could create the opportunity to explore the unknown together. Of course, there's the fear that that unknown will force each of the two, public health and primary care, to hunker down in their respective corners and wait and watch. I think Erik's work is a really good start to understanding a very basic question. If integration is so good, why aren't we all doing it? The methods and approaches used in his study seem to me to be exactly what's needed in the context of so much unknown. The focus on getting good, rich, deep qualitative information from key informants. So it's good to see this piece of qualitative research as a part of the PHSSR field, if you will. I think that that there are at least three important findings in Erik's work that can certainly serve as springboard for additional work, and they're part of the key themes that Erik mentioned. First of all, the notion of coordinating specific efforts towards specific issues as a starting point for finding what Erik described as a safe, shared, and comfortable place to work together. I think a second important finding here relates to workforce training and the comments, the information that came through that theme. That one of the biggest hurdles to collaboration is developing a workforce that's capable of working, speaking, and listening effectively across these disciplines. I can't help but think immediately again of the academic health department concept. There are actually examples of academic health departments that involve not only, of course, the public health practice partner, but both public health academic programs or schools, as well as medicine. The one that Bill Keck was instrumental in establishing in Ohio is one of those. The one in Florida, Jacksonville and Duval County is another example of that. So I think there are opportunities, again, given the potential for the School of Public Health there at the University of Memphis to involve itself in new ways. And then finally, and this gets back to that notion as well, I think a third important finding here is the strong convening agency and the desire to be able to identify such a. Finally, as Erik highlighted, and I agree that the language is so important here, I do find it interesting that the 2012 IOM report focused so much on the term integration. I think a more appropriate term is synergy, this notion of synergy that Roz Lasker used in her Medicine and Public Health report in 1997, bringing different approaches and resources to the same goals such that the whole is greater than the sum of the individual parts. May be an easier way to think about and conceptualize the working of public health and primary care as opposed to the word integration. So I'll end here by posing a question to Erik about his thinking about those words, integration and synergy, integration, synergy rather than integration, and whether or not any of that came to the surface in the informative. So thank you very much.
Thanks so much, Paul. Erik, do you have a response to that question?
Sure. No, it's a great question, and I think that the best way I can describe it is if you use the term integration, it's hard enough to get face-to-face time with hospital executives, with healthcare executives. It's just the nature of a more corporate enterprise, and those of us who have spent time in the corporate world, I think, understand that very keenly. But when you talk about integration, there is initial, very strong, visceral hesitation and negative reaction. Not that they don't want to work with public health, but it's a harder concept to understand. And it requires, as Paul mentioned, the IOM spending a lot of time saying this is what we mean by integration. Whereas, and Paul referenced Roz Lasker's work, the concept of synergy is one that people in the business world, like healthcare, they get implicitly. If you talk about, hey, I'd like to talk to you about how healthcare and public health have synergies, where we can find those and develop those. It's a much easier conversation, and the word that I would use is generative. It generates more positive momentum if you approach it in that way. We use the term integration in our study because it was really steeped in the principles that came out of the IOM report. But I think moving forward, going back in time, if you will, to the work that Roz Lasker did, and using that term synergy, it probably be really key for all of us to think in terms of. Not that we discount what the IOM did and that continuum, because I think it helps frame the sort of synergies we're looking at, but it's certainly, as we're approaching and as we're discussing these sort of overlapping efforts with our healthcare peers, then the concept of synergy, I think, is much more powerful.
Thanks, Eric. Crystal, do you have any reaction to Eric's presentation?
I do. Great to hear from you all. I'm sorry if my voice is a little wavering. I'm sick and fighting a cold, so hopefully I don't get on a coughing fit. But first of all, Eric, I would like to say great research, and you've documented many of my challenges as a practitioner that I deal with on a regular basis. So although you listed, a limitation of 17 in your study, I think you could pick that study up and put it in Kentucky, and most of us would agree that we face the very same challenges. One of the things that I feel that I don't feel that it's necessarily healthcare or public health main role I think it's both our responsibilities to jump in, and I think to this point, healthcare and public health have seen each other as competitors instead of players, and I definitely agree with synergy would be my pick if we were going to choose words of whether integration or synergy is a better fit. But it's difficult as a public health practitioner to get into just to get in and start speaking the language get in front of, healthcare CEOs, CFOs, people that make bigger decisions, and really because they have seen us as, what do you want and what are you going to take away from us that we are doing and that may be profitable or maybe, and the thing that I say about that is we can't afford to compete. Public health has, we are mandated on so many different levels to do so many things that we definitely have constrained resources, and we spend a lot of our resources doing the mandates, and so it's very important, especially in the times that we're in, to become more partners instead of seeing, and that's a big challenge on both ends, and something that needs to be tackled. You talked about in your study the constrained resources, and people are shocked when I tell them that 85% of my budget is personnel, and I think there's two challenges there as well. So we have, 85% of my budget is my staff, and up until 10, 12 years ago, I didn't have staff that understood truly what public health was. They were hired to do a job, and they came in and did what was expected of them, but if you asked them what public health was or how they fit into the bigger picture, they couldn't answer that question. So we also have an internal challenge of helping our internal folks understand why they do what they do and how they fit in the bigger healthcare picture, and that's something that I deal with on a daily basis as well. So it's not just getting the community to understand; it's getting our internal people to understand. So I just wanted to make that note. I love your quotes. I agree with 90% of the quotes that were put in there, so that's always nice. And made some notes for myself, and I think I've covered them. So, you know, the biggest thing is we can't afford to compete in public health. There's no reason for us to compete for primary care services or clinical services. We should be driven by our community health assessments and determining what the needs are in our communities and addressing those, and involving the healthcare system from that angle. And that's what I'm doing in my communities right now, developing the relationships, you know, where when you walk in the room with the hospital CEO, he doesn't look at me as, what do you want from me? He looks at me as, oh, we're working on this project together. So that's been a shift. I've been in my position about 7 years, and it's taken a while to get there, but it's definitely needed, and hopefully we'll continue in that direction.
Crystal, thanks so much for the insight. Eric, do you have any sort of comments on Crystal's reaction to your presentation, or any thoughts about what she said?
Sure. Maybe just briefly, and it's interesting that she talked about how long she's been in her position and the progress she's just now starting to make. I think that what it really speaks to is the critical importance of relationships in the collaborative work that we're talking about here. That ultimately, when it comes down to an agency investing a portion of their resources, whether they're fiscal resources or human resources or capital resources, in a more collaborative venture, they do it for a couple reasons. And one is, at some level, they see a benefit, certainly, to their organization. But part of it, too, is the relationships. So they ultimately, when the local hospital can go to Crystal and say, okay, I get that you can do this now. Will you help us with our community health assessment that we need to do for our community benefit requirements? And then Crystal can be ready to say, yeah, we're on board with that. This is what we can do for you. This is how it would work. I think what would be interesting, and a lot of us are starting to look at this concept of the places where there are implicit synergies, like the community health assessment. More and more public health departments that do these anyway, especially those that are looking at accreditation standards. They're poised and primed and ready to do this, and their people know how to do it, and their people have the connections they need to do to really get out there. But they are limited and constrained, and hospitals know what they want, and sometimes they just think in terms of, well, we have this one zip code that we're going to attend to, whereas they could invest those same resources and maybe get a bigger product out of it and get more out of it by working with the health department. And so I think it behooves the leaders of these local health departments especially to engage the way Crystal does with their local healthcare partners to say, this is what we can do for you. If you're interested, let us know. We're here to help. We're here to make your job better, and we believe that we have something we can offer you. And if we start thinking in terms of that, not what we can get from others, but what we can provide for others, and help them to see that, then I think we'll start to get at the sort of collaborative relationships we're all striving for. So I love Crystal's comments. She really hits it with the relationships.
Thanks, Eric. We have time for a few questions, so if you have any questions, please type them into the chat box. If I could have a question, Eric, related to your last comment. So you had spoke earlier in the presentation about, this dual definition of population health that's, often kind of at odds with each other with healthcare and public health, and you suggested kind of embracing this dual definition. Just wondering, do you think there might be an opportunity to kind of come together and find a common definition of population health that might help drive these two, what are now separate enterprises, closer together? And what might that look like, do you think?
Well, that's a loaded question.
Very loaded question.
I think the opportunity is there. I don't know if we will ever get away from the different perspectives that the agencies have. I mean, it's if you are a primary care organization and you're seeing 40% of your people have diabetes, you're dealing with chronic disease, right? You have very specific populations you're dealing with. I do think that there is hopefully we can get to a more broad community health sort of definition, and maybe community health is what ultimately we try and frame it as, because public health, I think it's more helpful to define public health by its governmental agency functions, because people need to understand what public health is in order to really engage it more fully. And so if we start talking about the health of the public or the public health, the waters get muddy. Community health might be the best way of framing it. I think healthcare has a community health notion already. Population health is kind of a catchphrase, and I think we just need to be careful with it. Is really what my comments were directed at.
I appreciate that. There's no questions in the chat box yet, so I have another one. You, on slide 18, you looked at your themes, right, of your research, and I was kind of surprised to find that developing the business case and incentives for kind of, monetary incentives for collaboration was only cited by 41% of your participants. I'm just wondering if you think that different organizations that might have more of an emphasis on shared savings, like ACOs, might rate that much higher.
I think so. I guess what's interesting, it was interesting to me too, Rick, that it didn't come up more, especially with the number of CEOs of multi-hospital healthcare systems. I mean, these are healthcare systems that have huge profit margins or losses on any given year, depending on what's going. And so for them to not think in terms of that, I think what they saw more was this, and I think it came out in both involving, in developing and supporting a convenient agency. They want to see public health take the lead. I think they mostly get it. The business case, yeah, it's important, but ultimately what they're looking for is the leadership role, and then the business case would follow. It's the best way I can describe how those conversations went. Again, this was 17 different people talking from different angles, and half of them were talking about this. But it really is, what they're looking for is the leadership to say, we're ready to own this, and this is what we can do, and then the business case would follow. I think that they can make, the hospital executives can make their own business case why they're going to invest in this. They don't necessarily need public health to do that, but public health should probably be ready to do it.
Right. And I kind of have one last related question. So your current population study was really, it was hospital administrators, it was some public health folks. What's next? Is it to look at other healthcare organizations and how they might collaborate with public health, or is it to kind of take what you found here and see if it's more generalizable to a larger audience? What do you kind of think are the next steps of this research? Answer these questions.
Sure. Well, I think one of the big next steps we're working on, and I have some really great projects developing both within Tennessee and in other places with some other colleagues with to look at, for one example, the community health assessment processes and how that might be an opportunity, or are there links between accreditation standards for the public health and whether they're engaged in collaborating with healthcare? Does accreditation requirements for public health departments drive public health to lead out and collaborate more with hospitals? I'm actively working on a proposal to get the hospital perspective. And I think some of the hospital perspective comes out really strongly in the study that Larry and Scutch did and their colleagues, which I think is a great dig into very different projects across the country. But I think it's important for us to really just concentrate on the hospital perspective, the healthcare perspective, if you will, and say, okay, how do we make this work more fully for you? Tell us what we're not getting, and really illuminate that for us. I think that there are people within healthcare who really understand what public health can do, but I don't think that it's trickled down yet. And so the next step really is by doing that to trickle down. And then I think that there has been some work done in the past in looking at community agencies. Paul and I are involved with some others in a study to look at these county health councils that are multidisciplinary groups within specific jurisdictions to drive collaboration. I think there's some opportunity there as well to continue to dig deeper and understand multi-sector, not just health and healthcare, but what about business and what about education and economic development as well.
Thanks. We have one last question. Sarah Newman typed in. This is a quick one. Did you consider involving payers in your study, folks who are paying for the services?
Yeah, it's a great question, Sarah. We actually tried to get somebody on the study, but we're not able to get it scheduled. It was incredibly laborious trying to get people to respond to being part of the study, as any primary data collection is, especially something like interviews. We just weren't able to get into it. It is an important perspective, and I think would be interesting to actually do a study of payers, just payers, and see what their perspectives are. But we tried. They just never got in line with us and got in on it.
Thanks. Well, Erik, Crystal, Paul, thanks for your time. We appreciate it. Thank you all for coming. We have a couple notes or shameless plugs to go over before we stop. The first one is the 2015 PHSSR Keeneland Conference is April 20th to 22nd, 2015. Our call for abstracts ends tonight at midnight. So if you want more information, go to www.keenelandconference.org or publichealthsystems.org. And our future webinars, our next webinar coming up is like January 7th. And it is, the theme of that webinar is the impacts of the Affordable Care Act on state and local public health. Michael Mates from the National Opinion Resource Center at the University of Chicago will be presenting on some research NORC has done, I believe, with ASPE. So thank you so much.
Thanks, Rick.
Thanks, Rick.
Thank you.